So what about ERCP? That's the classic actually, and that's a test which is usually done primarily. And I will try to explain the standpoint in which clinical scenario ERCP should be done. I would like to mainly talk about the proximal, the central cholangiocarcinoma, because the distal bile duct cancer is treated like pancreatic head cancer, and there are not so many uncertainties actually. So if you have a patient, jaundice, cholestasis, dilated bile ducts, try to refrain from the first reaction to put the patient on the ERCP table. So the most important thing in those patients is not to do ERCP primarily. Just think whether it could be a central bile duct stricture or central bile duct tumor, in which case you should not be doing ERCP first as a first measure. So the most important issue is to recognize the central cholestasis before further measures. Actually, this could probably be done by a good ultrasound already, that you have a normal CBD and dilated intrahepatic ducts. Don't do an ERCP right away. You have to think about the treatment concept, if it's likely to be a central cholangiocarcinoma, whether it's going to be curative or palliative, and direct cholangiography by ERCP or anything else should be done later and targeted. Why? So this is a very nice ERCP where you see the hilum very nicely, everything is filled, but for the patient it could be a disaster because you get under pressure to drain everything. And as I will show you in a second, maybe it's not necessary to drain everything primarily. But it depends on the therapeutic approach. And I've been working in different hospitals. I started off in a hospital where the entire focus was on the GI tract, and biliary cancer was considered a palliative thing, Klatskin tumors. But then I went to another hospital where the surgeon resected all the Klatskin tumors. So I got to know an aggressive surgical approach, and in that case, it's counterproductive to do this early filling of ducts, because the aggressive surgical approach is usually a right lobe resection, sometimes extended as a rule. And if the remaining left liver lobe is too small, there are measures by angiographic embolization to enlarge the left lobe. Of course, metastases have to be excluded. So in that case, actually, only the very advanced Klatskin tumor or cholangiocarcinoma is then treated palliatively when there is no curative resection possible, but all the others are at least attempted to resect, and this is how the tumor could look like. So, and what you are doing is to leave the segments here, and these are then the segments which should be drained preoperatively. So you should not bring contrast into those segments, because this part of the liver will be embolized, the vessels will be embolized, and if there is infection by the contrast material, there's a higher risk of cholangitis. Of course, it depends on the tumor spread, it depends on metastasis. So this is the kind of test you have to do. You have to do a CT to see whether you have a visible tumor, which is not always the rule. And if there's a suspicion of a Klatskin tumor, you should be doing a volumetry of the left side to see whether it needs a preoperative enlargement. And number two, ERCP is not really easy in those cases. So here you have the first filling. You see, okay, that's a bile duct. Here's the stricture, and here we have the left side and the right side. And then you inject further and get confused because you don't know what's happening. But still, above that picture, you have here a drain in the left side, but there is still a segment on the right side which has not been filled. Look at this. This looks pretty complete, but there is still a segment which you have forgotten. But again, this is usually not necessary. So you should not try to fill everything and drain everything. Even if this is a wonderful ERCP and shows everything, it should be avoided. And this is the test of choice. Sometimes radiologists are not careful enough and they just make a standard MRCP, and the outcome is that you don't see much. So we have learned from radiologists cooperating with the endoscopist that MRCP is also operator dependent, and it usually can delineate the extent pretty well if they try hard. So what do we need to know? We need to know the longitudinal extent as precisely as possible, but also as non-invasively as possible. And that's the dilemma of ERCP. It's, of course, the best ductal visualization. It might be technically demanding, but as I said, filling of all ducts then requires drainage and increases the infection risk. There is some tissue diagnosis possibility. The accuracy is a little bit limited, as you have heard, and there's the question of the influence on the further approach. And this is what you should not do. This is what you often see on ERCP, and most patients come with a small stent here, somewhere in the bile duct. In fact, if this is an extensive Klatskin tumor, it's the medial segment of the right side, and there is more to come. This is the full right side, but the left side is sometimes disconnected, and you cannot fill it. So you, and this is in the resection concept. This is the site you should preoperatively drain, which might be possible with guide wire manipulations from internally, but sometimes you need PTCD. So what about preoperative drainage? For a lecture, it's very convenient to look at meta-analysis, although I'm not so convinced of the quality. Usually, preoperative drainage is not necessary for pancreatic cancer, at least over all bilirubin levels, and the studies show there's no outcome difference, but maybe a higher morbidity. So consensus a few years ago among the surgeons, this is a surgical journal, is to do it in selected patient jaundice and the need for preoperative antineoplastic therapy. So there's always a certain bilirubin level where the surgeons require drainage, maybe it's 15 or 20 or whatsoever. And of course, then the negative consequences. The question is, do we do by ERCP or PTCD? That's also a matter of discussion. There are some surgeons who do not want to have the stricture touched by a drain, and they are afraid of actually tumor spread, which is unproven, so they do not prefer an internalized PTCD. And again, here you see 3 meta-analyses with a highly variable number of studies, although they almost appeared at the same time. And they said that percutaneous drainage is more efficient and has fewer complications. So you have just seen from Paul what happens in clinical reality if you do a prospective randomized trial. This was aborted due to complications of the PTCD group, so you can probably throw away all these meta-analyses, but we can perhaps discuss it then. Tissue diagnosis has been touched or covered extensively by Rob. The question is there clinical relevance? Is there a different management concept if it's negative? Of course, if it's positive, it's confirmatory. There are a lot of cases of doubt, and people say, well, the surgeon wants to have it, the patient wants to have it. That's pretty vague. It can be the case in clinical reality, but at best, you have a concept what you do with the results if it's either positive or negative. Of course, this changes in cases of neoadjuvant therapy, liver transplantation, and in the entirely different and very difficult setting of primary sclerosing cholangitis. And you should bear in mind that some of the lesions could be benign. That's clear. This is a selected series from the University of Hamburg quite a few years ago, where they had 33 tumors manifested by ultrasound CT and also by the surgical, palpable by the surgical finger, and there were 6 benign lesions. So if you have an aggressive surgical approach and if you have a negative cytology or if you do not do this, you have a certain rate of benign lesions. This might be a selected series where this is pretty high, but this can happen. Palliation, a few final slides. There are several questions, ERCP or PTCD, plastic or metal, uni or bilateral. There are different concepts. This is an uncontrolled study by my predecessor in Berlin who just placed a plastic stent into the most dilated segment, just one, and had a massive bilirubin decrease. So you can do this. You can start by one side if you don't fill the entire bile duct, as I was explaining. And it, in fact, in reality, it can lead to a sufficient bilirubin decrease. But of course, that's not true in all cases, and in many cases, you have to go further. ERCP versus PTCD in the palliative setting, again says that percutaneous drainage is more efficient and has fewer complications. I think many people in this room would doubt this. Plastic versus metal says that metal stents is superior, no matter whether you place them bilaterally or unilaterally. Again, a lot of studies, but mostly retrospective or uncontrolled series. My personal experience with metal stents is that initially, if you place them, the results are fine. If there's ingrowth, then the reintervention gets pretty tough depending on how precisely you place them. You have seen a nice example this morning. So if you have access to all three metal stents from the duodenum, it's much easier to clean them. So if you do metal stenting, in those cases, they should be mostly uncovered because you block side branches otherwise, and the access from below should be maintained. Uni versus bilateral, that's also a complicated issue, and there's a few interesting details about some of the randomized trials. As we know, for plastic stents, it doesn't seem to make a difference. Metal stents, bilateral stenting seems to be slightly superior. I think that's kind of self-fulfilling prophecy, because if you do a unilateral metal stenting and there is a complication, then secondarily placing a second one, I think it's much tougher. Okay, so if there is a clinical suspicion of cholangiocarcinoma, that means a central cholestasis, not a distal one, think first no immediate ERCP. So to put the patient off the table when there's an immediate referral nowadays, everything is very condensed, so the patient jumps in and ERCP is done first. This should not be done. Agree on the treatment concept, including preoperative drainage, and then do further tests, which are non-invasive CT, MRCP, and then, if adequate, a targeted ERCP within the treatment concept, tissue diagnosis selectively, and palliation individual. Thank you very much.